Welcome. This is the New England Journal of Medicine. I'm Dr. Lisa Johnson. This audio program provides the full text of Chronic Pancreatitis, a clinical practice article by Sante Swarup Vege from the Mayo Clinic, Rochester, Minnesota, and Suresh Chari from the University of Texas MD Anderson Cancer Center, Houston. This article is published in the March 3, 2022 issue of the New England Journal of Medicine. Chronic pancreatitis. A 52-year-old man reports having had 2 to 3 episodes of acute pancreatitis each year for the past 6 years. During the past 6 months, debilitating continuous upper abdominal pain has gradually developed despite escalating treatment with meloxicam, tramadol, and recently oxycodone. He has 3 to 4 bulky, foul-smelling stools daily. He reports no weight loss. He has a 20-year history of alcohol use and a 25-pack-year smoking history. He has left his position at a company owing to frequent absences. CT of the abdomen reveals scattered pancreatic ductal calcifications, a dilated pancreatic duct, and an atrophic pancreas. How would you manage this case? The clinical problem. Chronic pancreatitis is a progressive fibroinflammatory disease. Classic chronic pancreatitis, usually associated with alcohol use, smoking, or certain gene mutations, typically begins with recurrent painful bouts of pancreatitis, followed by the insidious development of chronic debilitating pain during the next 3 to 5 years after an initial episode. Classic imaging findings of one or more of the triad of pancreatic ductal calcifications, ductal dilatation, and parenchymal atrophy indicate progression to chronic pancreatitis. A substantive subgroup of patients also classified as having chronic pancreatitis have neither pain, nearly 30%, nor a previous diagnosis of acute pancreatitis, approximately 50%. The primary form without pain or previous acute pancreatitis may be a different disease with a distinct pathogenesis. In practice, chronic pancreatitis is often used with a qualifier to describe other chronic inflammatory diseases of the pancreas, which share some, but not all, of the characteristic features of classic chronic pancreatitis. This general overview is focused only on classic chronic pancreatitis in adults. The annual incidence of chronic pancreatitis in the United States ranges from 5 to 8 per 100,000 adults, and the prevalence ranges from 42 to 73 per 100,000 adults. Risk factors include alcohol use in 42 to 77% of patients, smoking in greater than 60%, and genetic mutations in 10%. The disease is considered to be idiopathic in 28% of patients. Alcohol use greater than 80 grams per day for 6 to 12 years, and smoking, a smoking history of greater than 35 pack years, increases the risk of chronic pancreatitis by a factor of 5, have synergistic effects. 2/3 of patients with chronic pancreatitis are men, and risk is higher among Black persons than among white persons. Genetic mutations most commonly involve cystic fibrosis transmembrane conductance regulator, CFTR, serine protease inhibitor Cazal type 1, SPINK1, or chymotrypsin C, CTRC. More than 90% of these cases manifest as apparently sporadic early onset, less than 35 years of age, pancreatitis. Hereditary pancreatitis, a rare autosomal dominant disease caused by cationic trypsinogen, PRSS1 gene mutation, accounts for approximately 1% of all cases. Regardless of the cause, chronic pancreatitis confers a predisposition to pancreatic cancer. The cumulative risk is 1.8% at 10 years and 4% at 20 years of follow-up among patients with sporadic chronic pancreatitis, and 7.2% by 70 years of age among those with hereditary pancreatitis. Approximately 70% of patients present with episodic upper abdominal pain, nausea, and vomiting. Pain patterns include intermittent severe attacks with or without pancreatitis that occur early in the course of disease, type A, persistent chronic pain between intermittent severe attacks, type B, and chronic severe pain without severe attacks, type C, which is the most debilitating pain pattern. Chronic pain is attributed to peripheral and central neural sensitization that results in visceral sensitivity, allodynia, pain elicited by a stimulus that normally does not produce pain, and hyperalgesia. Severe disabling pain that warrants narcotic use disrupts patients' lives, with consequences often compounded by alcohol use and psychosocial factors, such as poor resilience and inadequate social support. Complications of chronic pancreatitis include pseudocysts, bile duct stricture, duodenal stricture, splanchnic venous thromboses, and pancreatic cancer. Loss of islet mass and insulin causes glucose intolerance and eventually diabetes, type 3C. Loss of counterregulatory hormones can cause wide swings in blood glucose levels. Exocrine pancreatic dysfunction can progress from a pancreas sufficient phase, stage 1 or 2, to pancreatic exocrine insufficiency, characterized by steatorrhea, stage 3 or 4. Pancreatic exocrine insufficiency occurs with near total, greater than 90% loss of pancreatic exocrine function. Prolonged steatorrhea leads to weight loss, sarcopenia, decreased muscle mass, and deficiencies of fat-soluble vitamins A, D, E, and K, vitamin B12, and other micronutrients, zinc and magnesium, stage 4. The chronic inflammatory state and deficiency of vitamin D and possibly vitamin K often result in osteopenia or osteoporosis, with bone pain and low-impact fractures. Chronic pancreatitis is associated with increased mortality from any cause. Strategies and evidence. Evaluation and diagnosis. Evaluation for chronic pancreatitis and its complications includes a careful clinical history taking, laboratory testing, and imaging. Histologic analysis is not needed for diagnosis and is often not available. Definitive diagnosis rests heavily on imaging findings. Laboratory testing includes assessment of pancreatic endocrine function, screening for diabetes mellitus, and exocrine function, described later in this review. Imaging. Imaging methods include computed tomography, CT, magnetic resonance cholangiopancreatography, MRCP, and endoscopic ultrasonography, EUS. Endoscopic retrograde cholangiopancreatography, ERCP, is no longer recommended owing to complications and the availability of non-invasive imaging. Of these, CT is the most readily available and widely used. In a large meta-analysis, the sensitivity and specificity of CT, magnetic resonance imaging, MRI, and EUS did not differ significantly. But EUS is invasive, observer-dependent, and prone to false positive results. MRCP, especially after secretin stimulation, has the advantages of better delineation of the pancreatic and bile ducts, the absence of radiation, and safety in patients with allergy to contrast media or with renal insufficiency with the use of non-contrast T2-weighted sequences. However, MRCP takes longer and is more expensive than CT or MRI, is unsuitable for patients with claustrophobia, and can miss calcification. Examples of imaging findings and suggested interventions in painful chronic pancreatitis are shown in Figure 1. Other evaluations. Assessment of multiple domains is warranted, including the nature and severity of upper abdominal pain, imaging findings, nutritional status, substance abuse, disability due to disease, resilience and motivation for behavioral change, and effect of the disease on psychosocial function. Pancreatic exocrine function is evaluated by history taking and laboratory testing. Individual symptoms, abdominal pain, diarrhea, and bulky, foul smelling, difficult to flush, pale, or oily stools are neither sensitive nor specific for steatorrhea. However, a reduction in symptoms with pancreatic enzyme replacement strongly supports steatorrhea. Persistent steatorrhea is associated with weight loss and micronutrient deficiencies. In the absence of a classic symptom complex, exocrine function should be assessed by fecal elastase 1, measured in a single stool sample, and, when indicated, quantitative fecal fat, measured in stool collected over a period of 48 to 72 hours while the patient follows a diet containing 100 grams of fat daily. Measurement of the fecal elastase level is simple, inexpensive, and widely available. Levels below 200 micrograms per gram of stool are considered to be abnormal, but only very low values, less than or equal to 50 micrograms per gram, or even less than 15 micrograms per gram, according to one report, are reasonably predictive of steatorrhea. Abnormal levels above 50 micrograms per gram occur in many other conditions, including diabetes, old age, irritable bowel syndrome, inflammatory bowel disease, renal failure, functional dyspepsia, and any watery diarrhea, and have poor specificity for steatorrhea. The frequent mischaracterization of any abnormality in fecal elastase levels as pancreatic insufficiency has led to overdiagnosis and overtreatment. Quantitative fecal fat testing is available through many academic centers and major reference laboratories in the United States. Challenges to its routine use include patient adherence to the recommended diet, complete stool collection, and cumbersome manual laboratory testing and analysis. With proper instructions and adherence to the 100-gram fat diet for 2 days before and throughout the stool collection period, fecal fat testing provides the best estimate of digestive capacity. A normal value for the coefficient of fat absorption is at least 93%. And a normal amount of fat in stool is less than 7 grams per 24 hours. Elevated values occur in disorders of absorption and digestion. In routine clinical practice, a fecal elastase test can be performed annually as a screening test for pancreatic exocrine insufficiency. A fecal fat test should be performed to confirm pancreatic insufficiency if fecal elastase levels or vitamin A or E levels are very low, in the absence of the classic complex of symptoms of steatorrhea. Table 1 lists suggested assessments for impairments in biophysical domains, and Table 2 lists suggested assessments and interventions for impairments in psychosocial domains. Management. Indications for treatment in patients with chronic pancreatitis are pain, complications, and functional endocrine and exocrine insufficiency. Treatment options are described as follows. Pain. Management of pain in patients with chronic pancreatitis has traditionally relied on the biophysical model of health and disease, which posits that all symptoms have a structural basis. However, recognition of central sensitization and the role of psychological and social factors associated with chronic pain support expansion of management approaches to include attention to non-structural behavioral interventions. Management of pain starts with developing a strong patient-physician rapport and acknowledging patients' pain and disability. Patients should be educated about both structural and non-structural interventions. The latter are particularly important for patients with centrally mediated abdominal pain syndrome and impairments in non-structural domains. This is supported by evidence of a high incidence of ongoing long-term narcotic use, greater than 40%, for abdominal pain among patients who have undergone total pancreatectomy, particularly among those with prolonged preoperative narcotic use and alcoholic and non-hereditary pancreatitis. There is no effective medical treatment to stop the recurrence of acute pancreatitis. For acute and chronic pain, medical therapies include analgesic agents, antioxidants, and neuromodulators, for example, gabapentinoids and tricyclic antidepressants. Regular use of opioids should be avoided owing to risks of tolerance, addiction, narcotic bowel syndrome, and a paradoxical increase in pain due to opioid-induced hyperalgesia. Two meta-analyses of randomized trials of various commercially available antioxidant combinations, vitamins A, C, and E, and S-adenosylmethionine, have shown significant reductions in the number of days with pain and in narcotic use. However, the trials included small numbers of patients, and one trial showed no benefit. The recommendation to use these is based on potential benefits and the absence of adverse effects. Short-term placebo-controlled trials have shown reductions in pain among patients with chronic pancreatitis with pregabalin alone or in combination with antioxidants. Other neuromodulators, such as gabapentin, tricyclic antidepressants, and serotonin norepinephrine reuptake inhibitors, have also been suggested as possible treatments. But randomized trials of their use specifically for pancreatitis-associated pain are lacking. Although pancreatic enzymes can alleviate symptoms of maldigestion, a systematic review and meta-analysis showed no evidence of benefit for pancreatic pain. An integrated approach to biophysical and psychosocial impairments is shown in an algorithm in Figure 2. Interventions for pain in chronic pancreatitis are summarized in Table 3. Endoscopic therapy. Endoscopic therapy, predominantly involving the removal of stones in a pancreatic duct, dilatation of strictures, or both, is often the first intervention for moderate to severe pain, types A, B1, and B2, that does not respond to medical therapy. Extracorporeal shockwave lithotripsy is used for breaking up stones, either as a standalone therapy for stones less than 5 millimeters in diameter, or as an adjunct to ERCP. For strictures in a pancreatic duct, prolonged dilatation of approximately 1 year with the use of 10 French plastic stents with intermittent stent exchanges is generally warranted. Pain relief is reported in more than 70% of patients. Endoscopic management is also indicated for some complications of chronic pancreatitis, such as pseudocysts and pancreatic ascites. Surgery. Options for surgery for pain relief include pancreatic resection for persistent focal inflammation, standard pancreaticoduodenectomy and its variants, or distal pancreatectomy, drainage of an obstructed duct, longitudinal pancreaticojejunostomy and its variants, or a combination of both, Frey procedure, or, in the most refractory cases, total pancreatectomy with or without autologous islet cell transplantation. Complications of chronic pancreatitis, such as biliary entrapment or pancreatic cancer, are additional indications for surgery. For best results, it is important to consider surgery before the development of opioid dependence and neuropathic pain. 3 randomized trials have compared surgery with endoscopic therapy for painful chronic pancreatitis. All showed higher percentages of patients having pain relief with surgery than endoscopy, 34 to 78% versus 15 to 39%, with similar complication rates and mortality and a greater use of reinterventions in the endoscopy group. Because endoscopic intervention is less invasive and does not preclude subsequent surgery, it is typically preferred as the initial option. However, patients with persistence of pain despite endoscopic therapy should be reevaluated for surgery and non-structural interventions. Non-structural interventions. Important adjuvants to structural interventions include cognitive behavioral therapy to help change the way patients think about and cope with pain, stress management and resilience training to reduce anxiety and improve coping skills, dedicated pain rehabilitation programs that incorporate behavioral, physical, and occupational therapies, and treatment of addictions, nicotine, alcohol, and narcotics. On the basis of studies of the management of chronic pain in other contexts and of clinical experience with patients with chronic pancreatitis, these interventions improve functional status and psychosocial well-being. A recent randomized controlled trial showed efficacy of internet-based cognitive behavioral therapy for pain in patients with chronic pancreatitis. Exocrine pancreatic insufficiency. Treatment with pancreatic enzyme replacement mitigates the effects of steatorrhea. It is indicated if a patient has one or more of the following: classic symptoms of steatorrhea, suggestive but not diagnostic symptoms, plus a fecal elastase level of less than 50 micrograms per gram of stool or low micronutrient levels, or a fecal fat level of 15 grams or more per day. All Food and Drug Administration approved enzyme products are of porcine origin, and most are coated to delay degradation by gastric acid. Although enzyme therapy, usual starting dose 20,000 to 50,000 U.S. pharmacopoeia units of lipase activity, generally does not abolish steatorrhea, mean coefficient of fat absorption during enzyme therapy approximately 85%. It reduces symptoms and ameliorates nutritional deficiencies. Many factors influence the efficacy of enzymes, including the caloric and fat content of the diet, secretion of gastric acid, gastric emptying, altered anatomy, variable increase in extrapancreatic lipolysis, and bacterial overgrowth in the small bowel. The effectiveness of enzyme therapy may be increased by taking the enzymes with meals, distributed throughout the meal, distributing dietary calories across 4 or 5 meals per day, using acid-reducing agents, and testing and treating for bacterial overgrowth in the small bowel. Dietary fat restriction should be avoided to prevent weight loss and deficiency of fat-soluble vitamins and essential fatty acids. Pancreatic cancer. There is no effective screening strategy for early detection of pancreatic cancer in patients with chronic pancreatitis. In patients with hereditary chronic pancreatitis, alternating MRI and EUS have been recommended for screening without evidence of effectiveness or improved outcomes. Carbohydrate antigen 19-9, the best-known serologic marker of pancreatic cancer, may be falsely elevated in patients with chronic pancreatitis and is not helpful for screening. Areas of uncertainty. Further study is needed of strategies for early detection of chronic pancreatitis, prevention of recurrent pancreatitis and its progression, identification and assessment of centrally mediated chronic neuropathic pain, identification of pancreatitis-related diabetes, type 3C, as compared with other causes of diabetes, and early detection of pancreatic cancer. The natural history of chronic pancreatitis is not well understood, but is currently being studied in a prospective cohort study in the United States. Prospective Evaluation of Chronic Pancreatitis for Epidemiologic and Translational Studies, PROCEED. The relationship between exocrine and endocrine dysfunction, type 3C diabetes, in chronic pancreatitis, and the role of newer diabetes therapies in treating type 3C diabetes are uncertain. Larger and longer-term trials are needed to better assess pharmacologic, behavioral, and structural interventions for chronic pain, particularly neuropathic type, associated with chronic pancreatitis. Guidelines. Several guidelines have been published in the past 5 years, some involving overall evaluation and management, and others focused on one specific aspect of the disease. The recommendations in this article are generally consistent with these guidelines, except that guidelines have not addressed the evaluation and management of psychosocial domains contributing to chronic pain. Conclusions and recommendations. The patient in the vignette has chronic pancreatitis associated with alcohol and smoking, with both centrally mediated and pancreatitis-related pain, type B2. His history also suggests exocrine pancreatic insufficiency. Confirmation with fecal elastase or fecal fat testing is recommended. The authors of this review, Dr. Santhe Swaroop-Vege and Suresh Chari, would assess levels of fat-soluble vitamins, zinc, magnesium, vitamin B12, and glycated hemoglobin, and consider baseline dual-energy X-ray absorptiometry. If pancreatic insufficiency is confirmed, Drs. Vege and Chari would treat with pancreatic enzyme replacement and a balanced diet supplemented with fat-soluble vitamins and micronutrients, and with normal fat content. For his chronic pain, structural as well as non-structural interventions will probably be necessary. Given the presence of stones of more than 5 millimeters in diameter, extracorporeal shock wave lithotripsy would be appropriate with or without ERCP if a stricture in a pancreatic duct is present to clear the fragments, with a plan for surgical intervention if pain persists. For further management of ongoing pain, Drs. Vege and Chari would recommend pregabalin along with referral to a pain rehabilitation program, where available, including cognitive behavioral therapy. Counseling regarding alcohol, nicotine, and narcotic use, stress management, and resilience training are important. Periodic follow-up, initially at intervals of 6 months or 1 year, will be needed to evaluate the effectiveness of treatment and disease progression. This concludes the